Now, the next two kinds of anemia are due to problems with the red blood cells, like blood loss anemia or hemolytic anemia. So we'll talk about the blood loss anemia first. And there aren't many notes on the slide here, unfortunately, but it depends on the rate of hemorrhage and whether the bleeding is internal or external. With rapid blood loss, circulatory shock and circulatory collapse can occur. With more slowly developing anemia, the amount of blood cell loss must reach 50% for the signs and symptoms to occur. It's mostly due to losing intravascular volume, which can lead to cardiovascular shock. A fall in red blood cell count, hematocrit, and hemoglobin is caused by, or can be caused by, hemodilution, which is the movement of fluid into the vascular compartment. Red cells are normal in size and color. The hypoxia results from loss or proliferation of those cells in the bone marrow. So it takes about 5 days for the stem cells to differentiate fully, and so that will give your red blood cells a chance to come back. If it doesn't, it can cause an increase in reticulocytes in the blood. Can you remember what reticulocytes are? Red cells can return to normal within 3 to 4 weeks. Chronic loss of blood does not affect blood volume, but does cause iron deficiency anemia, where iron stores can be depleted. Okay. Hemolytic anemia is characterized by the presence of premature destruction of red blood cells, the retention in the body of iron and other products of hemoglobin destruction, and an increase in erythropoiesis. So all types are distinguished by normal cytic and normal chromatic red blood cells. And because the red blood cells have a shortened lifespan, the bone marrow can be hyperactive, resulting in more reticulocytes circulating in the blood. As with other types of anemias, the person is easily fatigued and shows other signs and symptoms of impaired oxygen transport. Okay, now the red blood cells in hemolytic anemia can be broken down within or outside the vascular compartment. Intravascular hemolysis is less common and occurs often as a result of complement fixation in transfusion reactions, toxic factors, or mechanical injury. Let's jump down and look at this one. Intrinsic cause could be caused by a defect of the red cell membrane. In this condition here that we're looking at, and I'm just looking to see where my notes go from this point, and here we are. So the hemolytic disease of the newborn is when antibodies from the mum are directed against fetal antibodies. And this can be in particular in the rhesus factor or blood transfusion reactions. So rhesus incompatibility is the most important, also called erythroblastosis fetalis. And you can see there, it's due to reactions of the maternal antibody against the fetus. Okay, so in this condition, a rhesus positive infant of a rhesus negative mum has been sensitized. The mother can produce anti-rhesus antibodies, and they become sensitized after the first delivery of a child who was also rhesus positive, and they cross the placenta, and the first child's not normally bothered by it, but the second one is normally bothered because the antibodies do take a while to develop. After a rhesus negative mother's been sensitized, the rhesus antibodies from her blood are transferred to subsequent infants through the placental circulation. They react with the red blood cells of the recent positive infant, causing agglutination and hemolysis. And that can be pretty bad. That leads to severe anemia and compensatory hyperplasia and enlargement of the blood-forming organs in the baby, including the spleen and liver in the fetus. Liver function may be impaired, and decreased production of albumin, causing massive edema, called hydrops fetalis, can occur. If blood levels of unconjugated bilirubin are high because of red cell hemolysis, there's a danger of something called I'm having a blank on how to pronounce it. The K word you can see on the slide there. Kernicterus developing in the infant, and that results in severe brain damage or death. So several advances have recently been provided, and that can decrease the threat to the infants if they're born to rhesus negative mothers. So one is prevention of sensitization in the first place, identification of high-risk fetus, transfusion to the infected fetus. Now, you can also give an injection of rhesus immune globulin. That's a gamma globulin containing rhesus antibody, and that prevents sensitization in the rhesus negative mum who has given birth to a rhesus positive infant in the last 28 weeks. If sensitization's already developed, the immune globulin won't work. And luckily, sensitization has reduced rapidly, and so only a small proportion die in utero. So fetal rhesus phenotyping is now performed to identify at-risk fetuses, and so hopefully it's detected before it even occurs. So here's a diagram showing that hemolytic disease of the newborn, and so you can see here the mum has rhesus negative blood. The rhesus positive blood has entered her circulation. So now the mum is making antibodies against the rhesus positive blood. If she has a second child, those antibodies can cross the placenta and attack the red blood cells of the baby. Okay, now the next disorder of blood cells is called polycythemia. And this is where you get an abnormally high total red blood cell mass with a hematocrit greater than 50%. It's categorized as either relative or absolute. So in relative polycythemia, the hematocrit rises because of loss of plasma volume without a corresponding decrease in red blood cells. So that could be occurring with water deprivation, increased use of diuretics, or gastrointestinal loss. Relative polycythemia is corrected by increasing fluid volume. So dehydration is obvious for that one. Absolute polycythemia is a rise in hematocrit due to an increase in total red cell mass and is classified as primary or secondary. Primary is a neoplastic disease of the pluripotent cells of the marrow, characterized by an absolute increase in total red blood cell mass, accompanied by an elevated white cell and platelet count. So it most is commonly seen in men of a median age of 62, but it can occur at any age. The manifestations are variable and related to an increase in red cell count, increased hemoglobin and hematocrit, increased blood volume and viscosity. Early findings also may indicate a depletion of iron stores. Viscosity rises because the hematocrit increases and it interferes with cardiac output and blood flow. So hypertension is common, and you may get headaches, dizziness, difficulties with hearing and vision, etc. Because of the increased concentration of blood cells, the person may experience itching and pain in the fingers and toes. Hypermetabolism may induce night sweats and weight loss. Okay, then there are also abnormalities with platelets too that can occur. So secondary absolute results from a physiological increase in the levels of erythropoietin, commonly in response to hypoxia. So that could be living in high altitudes, heart and lung disease, smoking. The resultant release of erythropoietin by the kidney causes an increased formation of red blood cells in the bone marrow. Neoplasms can also cause secretion of erythropoietin, and that can cause polycythemia. Kidney disease, renal cysts can obstruct blood flow and cause hypoxia and cause an increase in erythropoietin as well. Treatment for the secondary polycythemia focuses on relieving hypoxia. So a continuous low oxygen therapy can be given, and it's all right. Bleeding due to platelet disorders reflects a decrease in platelet number due to maybe a decreased production or an increased destruction of platelets or an impaired function of platelets. Spontaneous bleeding from platelet disorders most often involves small vessels of the mucous membranes and skin. Common sites of bleeding are the mucous membranes of the mouth, nose, GIT, and uterine cavity. Cutaneous bleeding is seen as pinpoint hemorrhages and purple areas of bruising in dependent areas where capillary pressure is high. So thrombocytopenia is a reduction in platelet number. Also, thrombocytopenia, that's what we're calling it. It's an important cause of generalized bleeding. It usually refers to a disease where the number of circulating platelets is less than 100,000 microliters. I'm just trying to figure out how that compares to that one. Okay, the greater the decrease in platelet count, the greater the risk of bleeding. It can result from a decrease in platelet production, a decrease in platelet survival, or an increase in platelet consumption. The decreases in production, the first cause up here, could be to the loss of bone marrow that occurs in aplastic anemia, replacement of bone marrow by malignant cells, such as in leukemia, radiation therapy and drugs for treatment of cancer can suppress bone marrow function. HIV can also affect the precursors of bone marrow. Production of platelets can be normal, but excessive pooling in the spleen might occur. And so this takes 30 to 40% of the platelets before they're even released in circulation. Excuse me. Reduced platelet survival is caused by a variety of mechanisms. Some are immune and some are non-immune. It may be caused by anti-platelet antibiotics and antibodies, sorry. The antibodies may be directed against the platelets or the precursors of platelets. Okay, some drugs like quinine and certain sulfur-containing antibiotics may induce thrombocytopenia. These drugs act as haptens to induce an antigen-antibody response and the formation of immune complexes that cause platelet destruction by complement-mediated lysis. In persons with drug-associated thrombocytopenia, there's a rapid fall in platelet counts, and that happens after starting drug use for the first time. The platelet count rises rapidly after the drug has been removed. Then you can also get heparin-induced, and this is associated with the anticoagulant drug heparin. 10% of patients treated with heparin develop a mild thrombocytopenia within 2 to 5 days of starting the drug. And only 1 to 5% of them, it'll be life-threatening. So this is heparin-induced thrombocytopenia, or HIT, is caused by an immune reaction directed against the complex of heparin and platelet factor 4, which is a normal component of platelet granules that bind to heparin. That activates the remaining platelets, leading to thrombosis. The thrombosis of HID results in complications such as deep vein thrombosis, pulmonary embolism, myocardial infections, and stroke. And about 20 to 30% of people die from that. The treatment requires immediate discontinuation of the heparin therapy and using different anticoagulants. Okay, the next thing we're going to look at is hemophilia, and there's 2 kinds of diseases that we'll look at: hemophilia and von Willebrand disease are the most common inherited disorders of bleeding. Hemophilia affects 1 in 5,000 males, and von Willebrand 1 in 1,000. Hemophilia is a deficiency of factor 9 and occurs in about 1 in 20,000 persons, accounting for 15% of hemophilia. Oh, that's hemophilia B, sorry. There's haemophilia A and B. Okay, now haemophilia A is caused by defects involving factor 8 and a WF complex. It's synthesized by endothelium in the megakaryocytes, is required for platelet adhesion to the sub-earth endothelial matrix of the blood vessel. So you can see there it's quite important. We're not going to go into a whole lot of detail, only that haemophilia A is X-linked recessive, and so primarily affects males, but also can affect females. Okay, now there are a number of other disorders of coagulation, and some of these are called acquired disorders. So coagulation factors 5, 7, 9, 10, 11, and 12, plus prothrombin and fibrinogen, they're actually synthesized in the liver. And so in liver disease, the clotting factors are reduced and bleeding can result. Of the coagulation factors made in the liver, factors 2, 7, 9, and 10, and prothrombin require the presence of vitamin K for normal activity. In vitamin K deficiency, the liver produces the clotting factor, but it's not active. It's in an inactive form. Vitamin K is a fat-soluble vitamin that's continuously being made by intestinal bacteria. This means that a deficiency is not likely to occur unless intestinal synthesis is interrupted or absorption of the vitamin might be impaired. Vitamin K deficiency can occur in the newborn before the establishment of intestinal flora. It can also occur as a result of treatment with antibiotics that might destroy the intestinal flora. Because it's fat soluble, this vitamin K is fat soluble, its absorption requires bile salts. So it could be also as a result of impaired fat absorption caused by liver or gallbladder disease. All right, now this is also talking about disorders that cause the clotting to occur. So hypocoagulability causes excessive clotting and contributes to thrombus formation. It can result from conditions that foster an increase in platelet numbers or function, or accelerated activity of the coagulation system. Thrombocytosis is an elevation of platelet count and can occur as a reactive process or as an essential process. Increased platelet function usually results from disorders like damage to the vascular epithelium, disturbed blood flow, smoking, anything that causes and produces factors that promote adhesiveness and aggregation of the platelets. So a number of factors can do this. There's an antiphospholipid syndrome that causes venous and arterial clotting and can affect blood flow around the body. So a thrombus is a clot. An embolus is a substance that travels through the bloodstream and blocks and lodges in a smaller vessel. So these kinds of things can be treated by anticoagulants, antiplatelet drugs, and fibrinolytics, which break down the fibrin clot.